Thank you very much, Simon. I would like all the speakers to get into these nice chairs and start some questions.
Here, like Alan. Only the Americans get that.
Okay, questions, please. Right.
Thanks for the session. Question for Eamon. Eamon, you showed us the predictive value for the squeeze and presented sensitivity and specificity. It was a bit rushed, but if I did the likelihood ratios right, we ended up with a likelihood ratio of about 3 or 4 if the test's positive, and if you've got about 10 out of 50 of you guys, that means we've gone from about 20% to 50% when the test's positive, i.e. they're 50% likely not to have an injury. Are you still, this is the test I should be doing for these guys pre-season?
Well, I have to say you're more au fait with statistics than me, because I haven't looked at the likelihood ratios yet, so it's something that we can discuss afterwards and go into it in depth with you a little bit more, if that's okay.
Next question.
I'm Thomas Ødegaard, Norway. Thanks for a beautiful session. I have a question for the whole group, but especially Christian Thorborg. Your findings was when you did the eccentric measurements as far as deficity. What about pain? And what is your experience, and how do you deal with the pain as far as strength measurements and strength? Thank you.
Yes, thank you for that question, Thomas. Yes, we have. The paper is out. It's freely online on the OJSM, so you can get it there. There's a table on pain, so they've reported pain during testing, because I agree that's very important, and it's a question we always get, that they have reduced strength because they have pain. In that table, you can see that they do have pain in the football group. And they have no pain in the control group. So from that perspective, they are different, also statistically. The interesting thing is that when you look at the isometric strength measures and compare that to the eccentric measures, they report similar amount of pain with no statistical difference. So, I mean, they are different from the control group, but you cannot explain why it's only the eccentric one that comes out as a deficit. Because pain-wise, they're exactly the same, actually. They have a median around 5 to 6 when we do the testing. But it's a very relevant question. I would still say, though, because a lot of physiotherapists they don't like testing where they have pain and they say, oh, then it's not a real strength measure. We are more interested in the eccentric output, because that's the output you can transform into function as well. So whether you have pain or not, that's also going to influence you when you actually want to go out there and accelerate or sprint or change direction. So in that sense, I think it's still a valid measure as well to make. But there's actually no difference between between the two tests within the group of the people having pain. Do you want to comment on that?
I can't. I got this thing on, I think. So, at our institute, pain during a strength test we think it's an invalid strength test. Yes, you can gather information out of that, but if you look at the study that our institute did in the shoulder, when we injected lidocaine in the shoulder, we measured the strength with pain, and then we measured after a lidocaine injection, saw the strength go up 20 to 30% even in the shoulder. I'm not so sure the same thing would happen with the adductors if you eliminate the pain, because your force production is going to be less because there's pain inhibiting it. How you use that information, well, that's a whole different question, which you alluded to. But it could be controversy there.
Yeah, no, I agree that especially the theory says that you cannot test strength when you have pain, but the interesting thing is, especially the isometric ones, we can just easily the same measures with the isometric testing, even though they have quite a lot of pain. So they can actually push through that. I think one of the reasons why they push through is because we test them. They have to do it 4 times, and it will keep going if the last one is not the highest one. And what you see, especially in those with pain, is that the first one and maybe the second one is a bit lower, but then they actually are able to push through that. So I think, yeah.
Andreas?
I have a question for Mr. Hahn.
Just one mic.
Sorry, here, better. You seem to be preferring the pressure cuff for your squeeze test. Before we set up the screening here at Aspetar, we played around a little bit with the different pressure cuffs that we have, and we found out that there's a big variability in the different producers and also the age of the pressure cuffs. So that needs to be considered when you report these normative values and discriminative values. In relation to that, we chose to use the handheld dynamometer for the Newton meter values. Do you have any?
I guess I'm coming at it from maybe a little bit of a different perspective, and maybe I should clarify that. So if we're thinking about large-scale screening with athletes, indeed on a weekly basis or pre-season, what we have to think about is, the utility of the device and the ability to get a proxy of isometric adductor strength through a mechanism that doesn't involve a lot of operator time dependency. So with the boys down in the rugby team that we do some research on, we've actually looked into player self-assessment of adductor strength using the squeeze cuff as well. We are confident that is a reliable measure. I agree with some of the comments that have already been stated that it's a bilateral test and you're not getting a unilateral value. But going back to your question, yes, there is some variability with the different sphygmomanometers that you do use, but they're easy to replace.
One more question.
Thank you. Great session. Håvard Moxnes from Oslo. Predicting injuries is very interesting, but returning patients to sport is also very hard. Could you comment on the use of strength testing as part of a return to sport decision? Would you use the same eccentric tests and have criteria that they should have normalized values, or should it be without pain?
I can do that for you. If you go back to our intervention study, we did have players that were injured in the intervention study, and we take it through clinical milestones. The first clinical milestone is to have isometric, 100% full isometric contraction of the adductors. Then be able, in the sideline position, lift the leg up against gravity. Once they can get there, then we found we can start isotonic training, and we'll start them on isotonic training there. Progress to eccentrics. Once they can start doing eccentrics, then we'll put them on the ice in terms of ice hockey. That's our clinical milestone for getting on the ice. I think the adductor squeeze test is very useful, though, in returning people, because if they have any pain on that, and anecdotal again, totally anecdotal, but if they have any pain on the adductor squeeze test, we got to back them down, it seems. I don't know if that's you guys' experience, but that's what we're finding.
I'll comment on that. I agree. I think one of the nice thing about Tim's suggestion is that actually based on some data as well, because a lot of the return to play that we state is just pure theory, really. Like you have to be in within 10%, 5%, 20%, or you have to be able to run through this and stuff like that. And it's just anecdotal, and it has to be anecdotal because we doesn't have anything else. So I think that's also the way we're going. We're trying to, now we have the reliable measures and we know what we're measuring. Now we have to try to figure out what actually makes a difference in relation to the return to sport. But that's why I've always been sort of looking into Tim's data because and his papers, because they actually had something there around the 80% that we can use. But if you look at the graph that I had in my talk, the guy with the same kind of injury that were back in 10 weeks, and you probably thought that was a little bit too soon actually, and for the other injury it took him 12 months. I couldn't hold him back from sport for 12 months. So again, getting him back to 100%, then he would have said at some point, well, I'm going to see somebody else now because she's just going to say to me every time I come that I can't return to sport. So I think we have to find out. I think that's what Andreas will be much closer at with his data, to actually find out what these measures mean.
I don't have evidence for this either, but we can all think about that adductor strain, the musculoskeletal adductor strain that happens in the middle of the season, whether it's football or hockey or cricket. You get one shot to get that person better in the middle of the season, it seems like. And if you don't get that person better in about 4 weeks, and they get re-injured, then it seems to take the whole rest of the season. I don't know if you all have found that, but you get that one shot at 4 weeks to get them better, and if you don't get them back all the way at that point, it seems to take an awfully long time after that, close to 8, 10, 12 weeks.
Yeah,
the season's over.
Can I come in there?
Yeah.
I think it's quite important when athletes do return to play from other injuries or other published data specifically relating to ankle joint injuries and hamstring injuries, ACL injuries. We know that athletes continue to present with significant neuromuscular deficits. So I think once an athlete has returned to play, I think there is some scope for continued screening of that athlete, and that we continue on our rehabilitation processes with those athletes to try and minimize the future risk of injury. And I think that's something that's oftentimes overlooked, that someone has come back after a grade 1 adductor strain, they're able to play, but the rehabilitation for their adductor strain stops, or same with their ankle joint injury, or same after returning to play from anterior cruciate ligament reconstruction and rehabilitation. So I think that's an important thing that is often very much overlooked.
We had 2 more questions here, I think, and we'll end the session.
I've got a question for you, Mr. Tyler. We've heard that muscle strain is a predictor for developing groin pain, and when you've got groin pain, then you see less muscle function. Do you think this is an adaptive or a maladaptive process? Do you understand what I want to ask? Because your conclusion was we have to train the adductor muscle, but when it's an adaptive process, I would like to discuss about it.
Well, we're limited by what we can measure, first of all. And maybe it's not the actual muscle physiology and complex of the muscle. Maybe it's the neuromuscular control, okay? So I really don't have the answer to that question, but I'm sure Andrew will answer it for next year.
I would think about muscle control as well.
Yeah.
Thank you.
Last question, Professor Griffin.
Thank you. Damien Griffin from England. Question for Christian. We heard earlier on that the clinical examinations that we're used to doing are not very informative. Do you think there's going to be scope in the future for us to develop objective strength and stability testing that might be more informative in making a diagnosis?
So just don't worry about the diagnosis and then just classify people according to other measures. Is that what you're saying?
Well, perhaps, but if we don't have good ways of making anatomical diagnoses by clinical examination, and we're going to hear about imaging tomorrow, but I think imaging has got quite a lot of difficulties as well, should we be looking at functional testing as a way of determining, in a sort of secondary sense, the mechanical or anatomical problem which the patient has?
Yeah, I'm sure that we need to think about classifying in another way than probably the traditional way of. It's a very Western way as well, the way we diagnose, that we just see some spot on an MRI and then we think that's the injury. So I definitely think that it makes sense to classify in a different way and maybe use some of these measures that you're also seeing today. But it might be that you still also have some anatomical you can say you have an anatomical trait or whatever, or even a subcategory, and then you apply different measures as that within that as well. But I think you have to rethink the whole diagnosis part and not just think about one structure causing pain. Certainly.
I got from today's lecture that we're much better at ruling something out than ruling in. Okay? So if I can rule out, then I can focus on the other stuff. So maybe that's where we're going to go. But I don't know who knows the answer to that.
Okay. Thank you very much all for participating. Especially thank you to our overseas speakers who were affected by jet lag. We covered those things. See you tomorrow at 9 in the morning.